Imagine the sheer joy, the excitement of a new life arriving on the farm. A newborn foal, all wobbly potential, taking its first steps. It's a magical moment, isn't it? Full of hope. But sometimes, despite doing everything right, that healthy start can just take a sudden, really terrifying turn. So today we're taking a deep dive into a condition it's a true medical emergency in the equine world, neonatal foal septic arthritis. Our mission here is to unpack what this joint ill, as it's sometimes called, truly is, why it's so devastating for these young animals and their owners, too. We'll look at the surprising ways infection takes hold and the incredible lengths vets go to fight it. We've pulled from comprehensive guides, detailed medical sources, really to bring you the most important insights. The goal is you walk away understanding this critical challenge much better.
Yeah, and what's truly fascinating here, I think, is how this disease, it's not just about one infected joint, right? It really puts the incredible fragility, the delicate balance of early life right into sharp focus. It just highlights how interconnected everything is in these tiny biological systems where, a seemingly small issue can rapidly escalate into something life-threatening.
Okay, let's unpack this then. So, at its core, neonatal foal septic arthritis it's a critical orthopedic condition. Basically, bacteria infect one or more of a newborn foal's joints. People in the horse world often just call it an infected joint or maybe joint ill.
Uh-huh. Joint ill is a common term.
And it's, surprisingly common, affects maybe 0.5% to a full 1% of all foals born.
Which doesn't sound like a lot, but when you consider the number of foals born, it's significant.
Exactly. And the immediate consequences, they can be really severe. I mean, you're looking at chronic lameness, possibly permanent loss of joint function. In the worst cases, it can even be fatal. And even if a foal survives to maturity, the stress on the other leg can cause problems too, right? Like that contralateral limb
It's a
laminitis.
major concern. Yeah, that constant
Mhm.
compensation puts enormous strain on the healthy limb.
So it really underlines why prompt recognition and, really aggressive treatment are just absolutely paramount. No waiting around.
Absolutely. And if we connect this to the bigger picture, the impact goes way beyond just the foal's health. Think about the economic burden.
Right.
Treating this it's extensive, it's prolonged, often means lengthy hospital stays multiple times under anesthesia to flush the joint.
Wow. Multiple times.
Oh, yes. Plus long courses of antibiotics, maybe even complex arthroscopic surgery, puts a huge financial strain on owners.
Mhm.
And then there's the athletic performance side of things. Studies show foals treated for septic arthritis might take significantly longer to start racing careers.
Ah,
And often, maybe only about half of them actually race, even if the infection clears up perfectly.
only half.
Yeah,
That's a big hit.
it is. Especially if multiple joints are involved. That makes the prognosis for racing pretty grim. For an industry that's so invested in athletic potential, well, it's a considerable economic loss.
So, okay, you've got this healthy foal 1 minute, then suddenly it's really sick. How do these bacteria actually get into the joints? It's not usually like a cut or something.
Not usually, no. The predominant route, the main way it happens is through the bloodstream, what we call hematogenous spread. Basically, bacteria are circulating systemically.
Hematogenous spread, okay.
And here's where it gets really interesting, biologically speaking. Developing foal joints have these unique anatomical features. Think complex blood supply with specialized loops of tiny blood vessels,
Okay.
where the blood flow is actually quite sluggish.
Hmm.
This makes the joints act like sinks for any bacteria floating around in the bloodstream.
Sinks, so they just kind of collect there.
Exactly. So even a brief period of bacteria in the blood, what we call transient bacteremia, maybe from somewhere else entirely, can settle in these joint sinks and start a full-blown infection.
Wow. So even a tiny amount of bacteria passing through can cause this disaster because of how the joints are built? That's kind of scary.
It really highlights their vulnerability at that stage.
So it's mostly bloodborne then, but can it happen other ways? You mentioned cuts earlier.
It can, yeah. While bloodstream spread is definitely the main culprit, you can get direct inoculation, like from a penetrating wound,
Uh-huh.
or maybe infection spreading from tissues right next to the joint. And sometimes, unfortunately, it can be what we term iatrogenic causes.
Iatrogenic. What does that mean exactly?
It's basically a medical way of saying the infection was inadvertently caused by a medical procedure.
Ah, okay. Like during treatment.
Precisely. Maybe contamination during an injection into the joint, intra-articular injection,
Mhm.
or infections after surgery.
Yeah.
Even with really strict sterile techniques, completely eliminating that risk is incredibly challenging. Like a tiny bit of hair getting carried in with a needle.
Mhm.
It can happen.
Mm.
And interestingly, just giving antibiotics preventatively for routine surgeries hasn't always shown a clear reduction in infection rates in horses. It shows how persistent these bugs can be.
So if the bacteria are usually spreading through the blood, where are they getting into the bloodstream in the first place? What are the entry points?
Good question. The most common entry points are the gut, the gastrointestinal tract, the respiratory tract, and critically, the umbilical stump.
The navel.
The umbilical
Oh,
step out, right? That makes sense. It's like an open door, isn't it? It essentially is, yeah. In that immediate postpartum period, it's basically an open wound, highly susceptible to bacteria getting in. If the hygiene isn't great or the care isn't adequate, it can just become this continuous source seeding bacteria into the blood, setting the foal up for serious issues like septic arthritis. Poor sanitation just makes it so much worse.
And what kind of bacteria are we typically dealing with here? Are there usual suspects?
Oh yes, there's quite a range. We often see various gram-negative bacteria, things like E. coli, Klebsiella, Pseudomonas, Salmonella species. E. coli is often the big one, especially in really young foals.
E. coli. So, from the gut.
Often, yes. And we also see gram-positive bugs, like Streptococcus and Staphylococcus. Interestingly, the prevalence of some, like Enterococcus, seems to be increasing. But what's really fascinating here, and maybe a bit surprising, is that strong link between those gut bacteria, the enteric gram-negatives like E. coli, and these joint infections. It strongly suggests the gut is a major reservoir, which just highlights how vital the integrity of that intestinal barrier is for the foal's overall health. A leaky gut can literally lead to infected joints.
Which brings us right to the question of why foals are so vulnerable. You said they're delicate. What makes them such easy targets?
Well, their immune system, or a lack thereof initially, is a massive factor. The number one risk factor is something called failure of passive transfer, FPT.
FPT, failure of passive transfer.
Right. Foals are born essentially immunologically naive. They have no real immune defenses of their own yet. They are completely dependent on getting maternal antibodies from the colostrum, that crucial first milk.
And they have to get it quickly, right?
Within the first 24 hours, ideally the first 6 to 12. If they don't get enough colostrum, or the quality is poor, it's like they're going into battle without any armor. They lack specific antibody protection. And it even affects how well their own immune cells, like neutrophils, work. Studies show about a quarter of foals with severe bloodstream infections, sepsis, develop septic arthritis, and FPT foals are almost twice as likely to get it.
So it's not just missing the antibodies, but their own immune cells are kind of underpowered too.
Exactly. Even beyond FPT, there's this inherent immunological immaturity. Neonatal neutrophils, those first responder cells, they're just not as good at migrating to infection sites or killing bacteria compared to adult cells.
Like their little army isn't fully trained yet.
That's a good way to put it. And their T cells are naive too. They haven't encountered threats before, so they don't know how to mount specific attacks. This baseline vulnerability means even foals that do get adequate antibodies can still be susceptible if they face a really heavy bacterial challenge.
Right, and it's not just the foal's internal biology, is it? The environment must play a huge role.
Oh, absolutely. Unsanitary conditions, improper umbilical care, those are major contributors. Meticulous hygiene is just non-negotiable. Dipping the navel stump, clean foaling stalls, it's all crucial.
And things like overcrowding.
Definitely. Overcrowding, high foal density on farms, that increases the overall bacterial load in the environment, increasing the risk for everyone.
Makes sense.
And also, septic arthritis often doesn't happen in isolation. It's frequently a consequence, a sequela, of a broader systemic infection, sepsis, like we mentioned. Bacteria circulate everywhere and then settle in the joints. So you often find concurrent problems like pneumonia or enterocolitis, gut inflammation, or an infected umbilical cord, omphaloflebitis, sometimes even brain infections.
Yeah.
And bone infections like osteomyelitis or septic fasciitis near the growth plates often go hand in hand with joint infections.
So seeing septic arthritis might just be the tip of the iceberg.
It often signals broader systemic compromise, exactly, which really influences the prognosis and means you need a holistic approach to diagnosis and treatment. You can't just focus on the joint.
Okay, so how do you spot the warning signs? For an owner, what are the first clues that something might be wrong with? Let's call him Little Spirit again.
Right, little spirit. Well, early detection is absolutely key. The most common and often the earliest signs are things happening right at the joint. So joint effusion, that's swelling. Lameness, which can come on really suddenly, sometimes non-weight-bearing lameness. Pain, when you gently feel the joint, palpate it. And maybe increased heat locally.
But you said it can be subtle.
Here's the catch, yeah. Lameness can be subtle or maybe even absent, especially if the foal is already weak or lying down a lot because of the systemic illness. And that's dangerous because it can be easily mistaken for something else, like, oh, the mare maybe stepped on him, and you lose critical time.
Ah, okay. Which joints are most common?
The hock, the ankle, the stifle, the knee, the fetlock, and the carpus, the wrist. Those are the big targets.
So what's the advice for owners?
For a good outcome, meticulous, twice-daily palpation of all the joints in any foal considered at risk is just essential. You're feeling for even subtle swelling, comparing one side to the other very carefully.
So it's not just about the joint itself. What about those more general body-wide signs that something serious, like sepsis, is brewing?
Yeah, and this is often frustrating because the systemic signs of sepsis in foals can be vague, really nonspecific, making early diagnosis tricky.
Vague, like how?
Like general depression, lethargy, maybe not wanting to nurse as much or at all, progressing to lying down more, recumbency. Temperature can be all over the place too. Fever is common, sure, but in advanced sepsis, they can actually become hypothermic. Their temperature drops too low, which can be misleading.
Anything else?
Yeah, rapid heart rate, rapid breathing. Sometimes you might notice their gums look very red, injected, or the capillary refill time is off. You press the gum, it should pink up right away. Petechiae, those tiny red spots on the gums, can appear. Maybe diarrhea too. It's often a constellation of subtle signs.
Okay, this raises a really important question then. How do you tell septic arthritis apart from other things that cause lameness or swelling? Because not every limp is an infection, right?
Exactly. That's a critical point. For instance, septic fasciitis infection of the growth plate might show swelling right over the growth plate area, not necessarily the joint capsule itself. Osteomyelitis, the bone infection, often happens alongside septic arthritis. Then you have things like nutritional fasciitis, which isn't an infection at all. That's usually in slightly older foals, maybe 3 to 6 months, related to growth and diet.
So how do you sort it out?
This is where diagnostic imaging becomes absolutely vital. X-rays, ultrasound, they help differentiate what's going on and, crucially, tell us if the bone itself is involved. That changes the whole picture.
Right. So once you suspect something's wrong with little spirit, the real detective work starts. What's the very first step a vet takes?
Well, the bedrock, the foundation, is always a comprehensive physical exam and getting a really detailed history.
History like?
Like anything that might point to problems with colostrum intake. Did the mare leak milk before foaling? Was the foal slow to stand and nurse? And then a systematic exam, carefully feeling every single joint. Like we said, lameness can be subtle or absent, so you need a high index of suspicion. Even if the foal isn't obviously limping, if other signs are there, you have to investigate the joints. You really have to be thorough.
Okay, exam done, history gathered. What's the definitive test? The gold standard for confirming a joint infection.
That would be synovial fluid analysis, analyzing the fluid from inside the joint itself. It's the cornerstone diagnostic tool.
And what are you looking for just by looking at it?
Well, even just the gross appearance gives you big clues. Normal joint fluid is pale straw-colored. It's clear, and it's really viscous, slippery, septic fluid, usually darker, maybe yellowish or reddish. It's turbid, cloudy, watery, and the viscosity is way down. If the cell count is really high, say over 30,000 cells, the fluid might be so opaque you literally can't read print through it.
Wow. Okay. And under the microscope, what tells you it's infection?
Cytology, yeah. You're looking for a really high total nucleated cell count, usually way above 5,000, often over 100,000 cells per microliter. And it's overwhelmingly neutrophils, those inflammatory white blood cells, like 80, 90% or more. And what's particularly fascinating and a key indicator of active severe infection is seeing degenerate and karyolytic neutrophils. That's a specific look they get when they're fighting hard and dying in the process. We tend to see significantly more of those in foals that sadly don't survive.
So those damaged cells are a bad sign.
They indicate a really intense battle, yes. Biochemically, the total protein of the fluid is usually high, over 2.5, maybe over 4 grams per deciliter. And a really critical finding is low glucose in the joint fluid compared to the blood glucose.
Why low glucose?
Because the bacteria and all the neutrophils fighting the infection are gobbling it up for energy.
Ah, okay, so the joint fluid is like the crime scene, showing the evidence.
Exactly. And then ideally you do microbial culture and sensitivity testing on that fluid. That tells you which bacteria is the culprit and which antibiotics will work best against it.
But you mentioned that can sometimes miss the bacteria.
Yeah, traditional culture sensitivity can be lower than you'd think, maybe only positive 25% to 80% of the time. Could be low bacterial numbers, maybe prior antibiotics interfered, or substances in the fluid inhibit growth. Using blood culture medium to grow the sample significantly improves the success rate. And now we also have more advanced methods like PCR.
PCR, like for DNA.
Exactly. PCR can detect bacterial DNA. It's faster, often more sensitive, and can find evidence of bacteria even if they're dead from antibiotics or present in really low numbers. Helps get targeted therapy started sooner.
Okay, so joint fluid is key. What about blood work? Does that tell you about the bigger body-wide fight little spirit is facing?
Oh, absolutely. The blood work gives crucial systemic information. A complete blood count, the CBC, is dynamic. Early on, you might actually see a low white count, especially low neutrophils neutropenia. In slightly older foals, or as the infection progresses, you might see the opposite neutrophilia, a really high white count. But a really significant finding, the one that screams severe systemic inflammation, is seeing what we call a degenerative left shift with toxic changes in those neutrophils.
That sounds bad. What does it mean?
It's jargon, I know, but basically it means the bone marrow is pumping out immature white blood cells really fast to fight the infection, and those cells often look damaged or toxic under the microscope. It's a major red flag. The body's reserves are being stressed.
Got it. What else in the blood gives clues?
We look at acute phase proteins, things like fibrinogen and especially serum amyloid A or SAA. These are proteins the liver produces rapidly in response to inflammation. They're like alarm bells.
SAA, why is that one special?
SAA is great because it goes up really fast when inflammation starts, and it comes down quickly when the inflammation resolves or treatment is working. So it's excellent for monitoring treatment effectiveness in real time. It also helps with antimicrobial stewardship, deciding when it's safe to stop antibiotics, for instance.
Okay. And IgG levels. You mentioned failure of passive transfer earlier.
Yep, checking IgG levels is crucial to see if the foal got enough colostrum antibodies. Less than 800 milligrams per deciliter is generally considered inadequate. Less than 400 is partial FPT. Less than 200 is complete FPT. Very important risk factor. And finally, the serum chemistry panel often shows abnormalities too. Electrolyte problems, low sodium, chloride, potassium, metabolic acidosis, signs of kidney stress, liver involvement. These aren't just markers. They contribute to how sick the foal is and need active correction.
So, blood work, joint fluid. What about pictures, imaging? How does that help?
Imaging is crucial, yeah. Standard x-rays, radiographs are essential. They tell us if the bone is involved, osteomyelitis or septic fasciitis. You look for things like bone destruction, lysis, or changes around the growth plates. Bone involvement seriously worsens the prognosis.
Okay, so x-rays for bone. What else?
Ultrasound is really valuable too. It's great for looking at the joint effusion itself, the soft tissues around the joint, like the joint capsule thickness, presence of fibrin. And critically, ultrasound is the best way to check the internal umbilical structures, the veins, arteries, urachus for infection, omphalitis, even if the outside looks okay.
So you can find a hidden infection in the navel stump with ultrasound.
Absolutely. It's a key part of the workup. And for more complex cases, we might use advanced imaging like CT or MRI. CT is often preferred in foals. It gives fantastic bone detail, it's faster than MRI, less anesthesia time, and the scanner opening, the gantry, is usually big enough to scan a whole foal if needed. CT really helps plan surgery if bone debridement is needed.
Wow. And you mentioned sepsis scoring systems. What are those?
They're basically structured ways to assess the foal systematically. They combine history, clinical signs like temperature, heart rate, breathing rate, and lab results like white blood cell counts to give a score indicating the likelihood and severity of sepsis or systemic inflammation. Helps with early recognition.
Okay, so once you have that diagnosis, the intensive fight begins. Sounds like time is absolutely critical.
It truly is. Septic arthritis in a foal is a flat-out medical emergency. Every hour counts. Delaying treatment, even just waiting for all the test results to come back, allows irreversible damage to happen to the joint cartilage. So immediate aggressive treatment is key. That starts with empirical broad-spectrum antibiotics, usually given intravenously right away to get high levels into the system and start killing bacteria.
Empirical means before you know exactly which bacteria it is.
Exactly. You choose antibiotics that cover the most likely culprits, gram-positives and gram-negatives, based on common pathogens in foals.
So antibiotics are clearly a cornerstone. What's the typical strategy there?
Right. Systemic antimicrobial therapy is fundamental. The initial broad-spectrum choice is often a combination. Maybe a penicillin derivative or a third-generation cephalosporin like ceftiofur combined with an aminoglycoside like amikacin. Amikacin is often preferred over gentamicin in foals because it seems to have a slightly lower risk of kidney toxicity, which is always a concern in sick neonates.
Are there antibiotics you avoid?
Well, trimethoprim sulfur combos aren't usually the first choice for severe sepsis. And fluoroquinolones, like enrofloxacin, are generally avoided in growing foals because they've been linked to cartilage damage, arthropathy.
Okay. And then you adjust based on the culture results.
Precisely. Once you get the culture and sensitivity back, you refine the antibiotic choice to target the specific bacteria found. Treatment typically lasts for several weeks, at least 2 weeks, if bacteria were found in the blood. If there's bone infection, osteomyelitis, treatment needs to be much longer, often until inflammation markers like fibrinogen normalize, or maybe a week after the joint looks clinically and radiographically clear.
And you mentioned stewardship, avoiding unnecessary antibiotics.
Yes, that's really important. Just giving antibiotics prophylactically to a foal, simply because it has FPT, without any signs of infection, is generally discouraged now. It just contributes to the huge problem of antimicrobial resistance. We need to preserve these drugs for when they're truly needed.
Makes sense. So, besides antibiotics flowing through the whole system, how do you get high concentrations right in the problem joint?
Great question. That's where local antimicrobial delivery comes in, and it's critical. One way is intra-articular injections, injecting antibiotics directly into the joint space. This achieves really high local concentrations, maybe 10 to 100 times what you get from systemic administration, but with less risk of systemic side effects.
Hmm.
Amikacin, gentamicin, ceftiofur are often used this way, usually daily or every other day for maybe 3 to 7 days alongside systemic treatment.
Okay, direct injection. What else?
Regional limb perfusion, or RLP, is another powerful technique, especially if bone is involved or the infection is severe.
How does RP work?
You place a tourniquet on the limb above the affected area, then inject a concentrated dose of antibiotic into a vein below the tourniquet. The tourniquet keeps the antibiotic concentrated in that limb region for about 20-30 minutes, bathing the infected joint and bone in super high drug levels.
Wow, that sounds intense but effective.
It can be very effective, yeah. And then there are antimicrobial impregnated beads, usually made of a bone cement material, PMMA, mixed with an antibiotic like gentamicin. These beads are surgically placed into the infected joint or bone defect, and they slowly release the antibiotic locally over weeks or even months. Very useful for chronic bone infections or low-motion joints where flushing is difficult.
So, killing bacteria is one thing, but you also have to physically clean out the joint, right? All that infected fluid and debris.
Precisely. Joint lavage, flushing the joint, is absolutely essential for every infected joint.
Yeah.
You have to remove the infectious material, the inflammatory cells and mediators, the debris, and just physically reduce the bacterial load.
How do you do that? Just needles?
Needle lavage, sometimes called through-and-through lavage, where you flush fluid in one needle and let it drain out another, can work for very acute, straightforward cases. You use large volumes of sterile isotonic fluid, like saline. But often, arthroscopic lavage is considered more effective, especially if the infection is more established or chronic.
Arthroscopic, meaning using a camera.
Exactly.
Yeah.
Minimally invasive surgery with a small camera, an arthroscope. It allows the surgeon to actually see inside the junk, be much more thorough in removing fibrin clots.
Fibrin, that sticky stuff.
Yeah, that fibrin acts like a scaffold or a web that traps bacteria and protects them from antibiotics and immune cells. It perpetuates the infection. So physically removing it, along with any inflamed joint lining, synovectomy, or dead tissue, is a huge advantage of arthroscopy. It disrupts the bacterial biofilms.
Okay. Isn't anything more aggressive than arthroscopy?
Yes. For very severe, chronic, or unresponsive cases, an arthrotomy might be needed. That involves surgically opening the joint more widely for cleaning and sometimes placing drains for continuous drainage. It's definitely a more aggressive approach, reserved for the toughest situations. But removing that fibrin mechanically is just critical.
Sounds like a full-scale assault. What if the infection has actually gotten into the bone, osteomyelitis?
Yeah, when bone is involved, osteomyelitis or septic fasciitis, surgical debridement is usually necessary. You have to go in and physically remove the infected and dead bone tissue.
How do you do that?
Often involves scraping the infected bone with an instrument called a curette. Advanced imaging, like using CT scans to guide the debridement, can really help make sure you get all the affected tissue, improving outcomes.
It's incredible the lengths you have to go to. And it's not just attacking the infection, right? There's all the supportive care, too.
Oh, absolutely.
Yeah.
Comprehensive supportive care is just as vital as the antibiotics and surgery. You can't succeed without it. Pain management is huge. These foals are painful, and that affects their ability to stand, nurse, everything. NSAIDs like phenylbutazone or flunixin are used, but cautiously because of the high risk of gastric ulcers in sick foals. Sometimes stronger opioids are needed.
Ulcers are common, then?
Very common in stressed sick foals. So gastrointestinal protection is standard practice medications to reduce stomach acid, like ranitidine or omeprazole, and maybe sucralfate to coat the stomach lining. Fluid therapy, IV fluids, is crucial for hydration, correcting electrolyte and acid-base imbalances, supporting blood pressure. Plasma transfusions might be needed for FBT or low protein levels.
And nutrition, if they're too sick to nurse.
Nutrition is fundamental for healing. If they can't or won't nurse, they need nutritional support, often through a nasogastric tube for enteral feeding or sometimes even total parenteral nutrition, TPN, which is intravenous feeding. They need a lot of calories to fight this.
And just basic nursing care must be intensive.
Meticulous nursing care, yes. Keeping them warm, clean, dry. Turning recumbent foals every couple of hours to prevent pressure sores and help their lungs. Patting their stall to prevent self-trauma if they're weak or having neurological issues. There are even some novel therapies being explored, like metabolic resuscitation, using cocktails of things like vitamin C, thiamine, and low-dose steroids to try and help the foal's own metabolic response to the overwhelming inflammation. Still under investigation, but interesting.
So after all of that, that intensive multi-pronged attack, what's the long view for little Sierra? What's the actual prognosis? Can they recover fully?
Yeah, looking at the long view, the prognosis for survival itself is generally considered pretty good, provided treatment is prompt and aggressive. Survival rates are often quoted in the range of, say, 78% to maybe 89%.
Okay, that's better than I might have guessed. But what makes the difference between survival and not?
Several factors tend to be negative prognostic indicators. Having multiple joints infected is worse than just one. Having bone involvement, osteomyelitis, is worse. Certain types of bacteria, like gram-negatives or mixed infections, can be tougher to treat. Seeing a high percentage of those degenerate neutrophils in the joint fluid is also linked to poorer outcomes. Concurrent systemic disease, like severe pneumonia or sepsis, makes things harder. And being very young, say under 30 days, or critically ill, generally lowers the chances.
And positive factors.
The biggest positive factors are getting treatment started really early, ideally within 24 hours of signs appearing, and using that combined approach, systemic antibiotics, local therapy like lavage or RLP, maybe surgery if needed. A multimodal attack works best.
Okay, survival odds are decent with fast action, but what about their future? Racing? Athletic careers?
That's where the picture gets a bit more guarded, unfortunately. Even if they survive and the infection clears, septic arthritis can significantly limit future athletic performance. We mentioned earlier they often take much longer to start racing, if they ever do, and having multiple joints affected is particularly bad news for a racing career.
Why is that? Just long-term damage?
Yeah, it's largely due to irreversible damage to the articular cartilage. That smooth lining of the joint just doesn't regenerate well once it's been damaged by infection and inflammation. That leads to ongoing lameness or poor performance. And, we have to mention the economic considerations again. The high cost of treatment can be prohibitive for some owners, sadly leading to euthanasia sometimes. And even if they survive, the loss of potential future athletic earnings is a significant economic hit for breeders.
It really underscores the importance of prevention then. With all that in mind, what are the absolute most critical things a farm owner or manager can do to stop this from happening in the first place?
Number one, without a doubt, is rigorous colostrum management and preventing failure of passive transfer. That is the single most critical preventative measure.
How do you ensure that?
Make sure the foal gets enough good quality colostrum. You can test the mare's colostrum quality with a refractometer or colostrometer looking for high specific gravity or high Brix percentage. And ensure the foal drinks it within the first 24 hours, ideally the first 6 to 12 hours when absorption is best.
And if there's doubt, or the mare has poor colostrum?
Supplement. Have good quality frozen colostrum on hand from other mares on the farm, or use commercial colostrum replacers. You can test the foal's IgG levels around 18-24 hours old to confirm they absorbed enough, aiming for levels well above 800 milligdl. If needed, IV plasma transfusion can boost their antibody levels.
Okay, colostrum is king. Step one, what's next?
Meticulous umbilical hygiene. That navel stump is a direct route for bacteria. Letting it sever naturally is good, then treating the stump with a suitable antiseptic like 1% Adine or maybe 0.5% chlorhexidine solution 2 to 4 times a day until it's completely dry is vital.
Right, closing that open door. What about the foal's surroundings?
Biosecurity and environmental management are huge. Clean foaling stalls are essential. Prompt manure removal is critical, especially since nasty bugs like Rhodococcus equine and Salmonella can thrive in manure and soil. Good ventilation, dust control, avoiding overcrowding. These all help reduce the overall bacterial challenge the foal faces.
And managing sick animals.
Absolutely. Isolate any sick animals immediately. Use dedicated equipment for them. Strict hand hygiene between handling foals. Quarantining any new horses arriving on the farm is also a really important biosecurity step. We can also leverage maternal vaccination to boost specific antibodies in the colostrum against things like salmonella or rotavirus. And sometimes hyperimmune plasma, rich in antibodies against specific bugs like R. equi, is given preventatively to foals on high-risk farms.
Finally, what about just keeping a close eye, ongoing monitoring?
Yes, early detection through screening programs can make a massive difference. This means daily observation, looking for subtle changes in attitude or nursing, that twice-daily joint palpation we talked about, routine temperature checks. On some farms, they might do routine blood tests like CBCs or SAA checks on young foals, or even screening ultrasounds of the chest for early pneumonia or the umbilicus for signs of infection. It's all about identifying at-risk foals or catching problems at the absolute earliest stage for prompt intervention. It really is a daily detective effort.
Okay, let's try and wrap this up. This deep dive, it really paints a picture of the immense challenges that come with neonatal foal septic arthritis. I mean, from how sneakily it can start to its potentially devastating impact. The level of diagnostic sophistication needed, that multimodal treatment, it really showcases the incredible dedication of veterinary medicine, doesn't it? It's quite something, the effort involved.
It really is. So what does this all mean for you listening? Well, I think this deep dive into neonatal foal septic arthritis really highlights just how delicate and interconnected everything is in these young animals. Their biological systems are just so finely balanced. And it makes you wonder, perhaps, as we keep pushing the boundaries of medical intervention, saving more and more of these critically ill foals, what are the broader lessons here? Lessons from this intensive, multifaceted approach that might apply beyond animals, maybe to any vulnerable population facing overwhelming systemic challenges. And thinking ahead, how does the constant, ongoing fight against antimicrobial resistance continue to shape our ability to protect the most fragile among us? How do we ensure we still have the tools we need to fight these infections for the next generation, whether they're human or animal? Something to think about.